to make this interesting and kind of tell a story. So not just say, we're going to go do X. We're going to explain how we got to where we are and why the issues that we're talking about are important to the members of the bleeding disorders community. So if you can go to the next slide, please, Sanja. I always like to start with a really big picture view of what is it that we as people with bleeding disorders, parents of people with bleeding disorders need from the healthcare system. And really, we need access to care and we need access to medication that preserves our health. And because those are expensive, we need a mechanism, health coverage, to pay for that care and treatment. So tomorrow, when we go to our virtual meetings, we're going to ask Congress to help people reach those goals by making private insurance more affordable, by helping low-income adults who currently are caught in a coverage gap. They don't qualify for Medicaid in their states of residence. And by a perverse glitch in the law, they also don't qualify for financial assistance to help buy private insurance. And last but by no means least, we're going to talk about these copay accumulator adjusters, an insurance company practice that targets copay assistance programs and thereby making it hard for people with bleeding disorders and other expensive health conditions to afford our treatments and to adhere to the treatment regimens prescribed by our doctors. Next slide. But I said that was maybe the 30,000 foot perspective, but it's kind of helpful to take a step back and take a historical look. I was a history major in college. Maybe that's why I always like taking this step back and thinking about how we got to where we are. So when we talk about access to coverage, we have to start with the Affordable Care Act, aka the Obamacare or the ACA. Next slide, please. And so just a very brief review. I think most of us, because people are such seasoned advocates, don't need this reminder, but maybe for the younger ones in our community, they do. Or a look back or a reminder of what the healthcare landscape was for people with bleeding disorders before the ACA. If you were lucky, you had insurance through your job, but for all too many of us with employer-sponsored insurance, that coverage might have come with lifetime caps or with annual caps, or it excluded care for bleeding disorders. It excluded coverage for the treatments we need. If you didn't have job-based insurance, then your options were even more limited, because for most people, in the individual insurance market, health plans could and would exclude you on the basis of your health condition, the so-called pre-existing condition, or could charge you more because of your health status. And Medicaid in most states was available only for kids, for disabled adults, or for parents of young children. In most states, non-disabled adults did not have access to Medicaid. Next slide, please. So the Affordable Care Act tackled those challenges and made a plethora of changes to the law in many ways that helped people with bleeding disorders, the coverage for people with pre-existing conditions, allowing us parents to keep our kids on our insurance age 26, targeting or getting rid of those lifetime caps and annual caps on benefits. But the two that are important to tomorrow's asks are the ones that I've highlighted in yellow here. The ACA provided an avenue for getting private insurance if you didn't have it through your job, and that was through the creation of the ACA marketplaces. But also critically, The ACA provided subsidies so people could afford to buy coverage in those marketplaces if their income would not permit them to otherwise. And the ACA allowed states to expand Medicaid to cover all low-income adults without requiring disability, without regard to parental status. Next slide, please. And so that made a real difference in the lives of people with bleeding disorders. And some of these are the stories that Will talked about in his presentation. If you go to the next slide, please, Sanja. One of the last events that I went to in person before the pandemic was a ceremony marking the 10th anniversary, the 10th birthday of the ACA on Capitol Hill. And we collected some of those stories from members of the bleeding disorders community to explain the difference that the ACA made in people's lives. But it hasn't all been smooth sailing. The ACA faced and survived over 60 attempts to repeal the law between 2010 and 2017. It survived 3 lawsuits that went all the way to the Supreme Court and a bunch that didn't make it that far. The most recent being the Supreme Court decision that came down in June of this year, rejecting what we hope is the final constitutional challenge to the Affordable Care Act. And numerous attempts in the past administration to chip away at the law via regulatory action, via rulemakings that kind of really eroded the protections offered by the Affordable Care Act. I do not by any means mean to suggest that the ACA is perfect. It is not. There are gaps and in the law that should have been fixed. And, you know, if our political situation were different, would have been fixed by fine tuning. Any big major piece of legislation could benefit from that kind of fine tuning. It just wasn't available in the case of the Affordable Care Act. So next slide, please. So as I said, the ACA turned 10. We had this briefing on Capitol Hill in March of 2020, and then COVID hits. Next slide, please. And it turns out in the wake of COVID, so where health insurance is more important than ever because of pandemic conditions and people needing to protect their health, but also in the wake of COVID's economic fallout with people losing their jobs, that the ACA proved its value. Between the marketplace and Medicaid, the huge spike in uninsurance that people were fearing did not happen. And when you think about a spike in uninsurance happening with the pandemic, you can realize, you know, how fortunate it was that the ACA served its purpose as kind of this safety net, providing a pathway to coverage for people. Next slide, please. So that brings us to 2021. And the first time after this 10 years of challenges and fighting a defensive fight for the Affordable Care Act, we saw the first time that Congress acted and the president signed a law that strengthens the Affordable Care Act. The American Rescue Plan Act, which we can say ARPA because it's less of a mouthful, was signed into law in March of 2021. And as I said, for the first time, this strengthened the Affordable Care Act by making insurance more accessible and more affordable for many people, at least temporarily. So notice that highlighting, we're going to come back to it. But for 2021 and 2022, ARPA, the Rescue Plan Act, increased premium subsidies and made them available to more people. And that means a lower cost of coverage for people who buy ACA insurance. So the premium subsidies, sometimes called APTC, Advanced Premium Tax Credits, go to people to bring down their cost of getting in the door, the cost of their premiums. And the Rescue Plan Act both increased the size of those premium subsidies, so more money going to people to help them afford coverage, and made the subsidies available to some people who previously were ineligible. It used to be that your eligibility for subsidies phased out if you earned income above 400% of the federal poverty level. And the ARPA got rid of that subsidy cliff. It said everyone is eligible for subsidies such that no one should have to pay more than 8.5% of income for the cost of a silver plan. So that really eased burdens for people who previously earned too much to get help and found themselves priced out of the ACA marketplaces. The ARPA also tried to offer an extra inducement to some of the Medicaid non-expansion states. None have taken them up on it so far. Next slide, please, Sandra. So what was the impact of this new law? We have almost 3 million people who have newly signed up for ACA insurance. The government opened a special enrollment period so that people could take advantage of the new subsidies. And if they had lost insurance because they lost their jobs, they could enter the marketplaces. Almost half of the new enrollees are paying premiums of $10 a month or less after tax credits. That is, making the entry into the system a lot easier. And consumers saved an average of $67 a month on their premiums. So you can see why people were able to enter the individual marketplace and pick up insurance when either they didn't have it before or they lost it because they lost their job. Next slide, please, Sanja. As I said, the premium subsidies expire. The ARPA provided these enhanced subsidies only for 2021 and for 2022. If you know people we're in open enrollment now, if you know people who are shopping for insurance for next year, please get the word out that there are great savings to be had in the ACA marketplace. But looking ahead to the end of 2022, that would be an enormous rate shock if all of a sudden the extra subsidies go away and people are faced with the full amount of the premiums pre-ARPA. So this is a print ad that ran in Politico with over 24 patient groups calling on Congress to make the enhanced subsidies permanent. Next slide, please, Sanja. I'm going to take another step back for a second and say, remember, we talked about two parts of the ACA working to prevent a surge in uninsurance after COVID. And one part was the ACA with the new subsidies, but the other part was Medicaid. And so, not surprisingly, Medicaid enrollment has really climbed during COVID. And that is, again, how Medicaid is supposed to operate. Medicaid is supposed to be a counter-cyclical program that picks up the slack when either disease or natural disaster or economic downturn hits. Next slide, please, Sanja. Just as a refresher, Medicaid is a public health insurance program. It's a joint federal state program that is over 50 years old that typically serves low-income families. States set up and administer their own programs, and the federal government provides a percentage of funding depending on how rich the state is. So a lower matching rate for richer states, a higher matching rate for poorer states. And right now, Medicaid is the largest single insurer in the US, covering 1 in 5 Americans, and we think up to about 30% of the bleeding disorders community. Next slide, please, Sanja. And so I've talked some about Medicaid expansion and the fact that the ACA gave states the option to expand their Medicaid programs to cover all low-income adults. The This map shows the states, it shows in blue the states that have taken up that option, and the states marked in orange are the ones that so far have failed to expand Medicaid to cover all low-income adults. Next slide, please, Sandra. And we know there is such a well-established body of work showing positive effects of Medicaid expansion across a range of categories in the 38 states that have acted to expand Medicaid. There's better health outcomes for specific health conditions. Hospitals and healthcare providers are healthier. There's lower levels of disparities. The behavioral health outcomes across the board. There is substantial evidence that Medicaid expansion makes a positive contribution to the health of people in the state, and HFA and NHF support the adoption and continuation of Medicaid expansion in all 50 states. Next slide, please, Sandra. So what happens to the low-income people who live in the states that haven't expanded Medicaid? That is a really tough situation. And that is where the term the Medicaid Coverage Gap comes from. Because if you are a low-income person in one of the 12 non-expansion states, you're not eligible for Medicaid unless you're disabled. You're not eligible just because of low income. But by a quirk of how the ACA was written and subsequently interpreted by the Supreme Court, you're also not eligible for those premium subsidies. You can perversely earn too little to qualify for premium subsidies. And that means you would have to pay the list price for health insurance. And if you are earning under 100% of the federal poverty level, which is just shy of $13,000 a year for a single person, you cannot afford to buy insurance without subsidies. You fall into a coverage gap without an obvious source of health insurance or a pathway to health insurance. Next slide, please, Sandra. This is what we know about people in the coverage gap. Most of them live in 4 states: Texas, Florida, Georgia, and North Carolina. They have very low incomes. Again, in 11 out of 12 of those states, you can earn $0 and not be eligible for Medicaid if you are not disabled, if you are not the parent of a young child. Despite having low income, nearly 2/3 of the people in the coverage gap are in a family with a worker. They themselves work or someone in their family works. There are racial disparities in who falls into the coverage gap. And we know that some in the coverage gap have significant current health needs. And certainly anyone with a bleeding disorder who found themselves in the coverage gap would be in that category. So we stand for people with bleeding disorders having access to quality health insurance that enables them to get the care they need to preserve their health. And that is regardless of where they live. Next slide, please, Sandra. So that long background brings us to our asks for tomorrow. Congress right now is debating a budget bill, sometimes called the Budget Reconciliation Bill, sometimes called the Build Back Better Act, also known as HR 5376. And that budget bill has a lot of pieces to it. We are interested in 2 in particular. We want Congress, as part of the budget bill, to make those ARPA enhanced subsidies, to extend them beyond 2022. We do not want people to face a sudden reversal where in 2023, their premiums go up by hundreds of percent. And extending the enhanced subsidies keeps insurance more affordable and therefore more accessible for millions of individuals and families. And we want Congress in the budget bill to provide a solution for the 2.2 million people who, through no fault of their own, live in states that have declined to take up Medicaid expansion. We want Congress to provide Medicaid or Medicaid-like coverage to the low-income Americans who live in those 12 states. Next slide, please, Sanjay. So that's our message to lawmakers as work moves forward on the budget reconciliation bill, HR 5376. Please take action to extend the enhanced APTC or premium subsidies, easing cost barriers for Americans who purchase marketplace insurance. And please act to cover the more than 2 million adults who fall into the coverage gap living in those 12 states that have failed to expand Medicaid eligibility. And on the right-hand side of the page, you see a letter that, again, you saw the Politico ad earlier. These are the groups in one of our coalitions. Mike had asked about, or is HFA striking its own way? And the answer is no on none of these asks tomorrow. Are we striking our own way? We are in a very large coalition of ranging from smaller groups like ours to enormous groups like the American Cancer Society, calling on Congress to extend the premium subsidies and to make and keep insurance affordable in the ACA marketplace, and to cover Americans who fall into the coverage gap. Next slide, please, Sanjay. All right, well, and this is actually the point at which I am going to transition over to my colleague, Mark, because we've talked about access to insurance via keeping those enhanced subsidies and via addressing the Medicaid coverage gap. But we know that a problem of underinsurance that Randy talked about in her introduction is very real. People who have insurance, especially in the bleeding disorders community and other communities that rely on expensive drugs to stay healthy, still face barriers to care. So I think with the next slide, Mark is going to take over, and then we'll be happy to take questions at the end. Thanks.
Sure. Thank you, Miriam. And I'm about to talk about an issue that I realize probably half of you could speak about even better than I can. I know there's several of you who've been very involved in this issue at your state level. But it is a very complicated issue, so I wanted to make sure that everybody had at least kind of a basic overview of it. And for the rest, I hope it's a useful refresher. Next slide, please. Now, Copay Accumulator Adjusters is a fancy, complicated name for what is basically the newest type of insurer cost containment tactic that we've seen. It's just another way where they are trying to avoid covering the costliest patients. And it focuses solely on the third-party assistance that you may receive for your cost-sharing obligations. So things like your deductible, your copays, your annual out-of-pocket maximum. And what happens is the insurer basically is saying that that assistance artificially inflates the cost of drugs, that it gives consumers an incentive to purchase higher cost drugs instead of lower cost generics. Obviously, as we'll get into, that's not a legitimate excuse in the case of hemophilia and bleeding disorders, since, as is the case with most specialty drugs, there are no lower cost generic alternatives. But what, from the insurer's point of view, what they're saying is copay assistance is bad. So what we're going to do is deny the consumer any benefit from it. So they will refuse to apply it to any of those cost-sharing obligations, your deductible, out-of-pocket maximum, or your copay. There is an alternative called a Copay Maximizer for our purposes tomorrow. That's really just a softer, less disruptive form of a copay accumulator where they spread out the effect over all 12 months. But both terms are basically the same thing. It's where the value of your cost sharing assistance is not getting credited. And so when you show up for your to the pharmacy for your medication fills, you'll find out that often completely by surprise, you have to pay the full amount of your annual out-of-pocket maximum upfront. And as you can see on the slide, that is a huge amount of money. Next year, it'll be $8,700 if you're an individual, and there's very few of us, probably none of us, who can write a check for that amount in order to avoid having our care disrupted and not being able to access the treatment that you critically need. Next slide, please. Now, again, as I may have mentioned, this is something that has just exploded over the last year or two. A couple years ago, we saw maybe just a handful of plans nationwide that applied copay accumulators. Now, every single state has plans impacted by this. More than 80% of people who get their coverage through private health insurance are now getting hit with some form of this, the accumulator or the maximizer. That number is only going to go up in the future. We already have 14 states where every single plan in the Affordable Care Marketplace is applying accumulators, so there's no way for a consumer in the marketplace to avoid it. And the large employer plans where most Americans get their coverage now have about 1 out of every 4, according to Kaiser Family Foundation, applying some form of accumulator. So this is just an emerging trend that's gotten to the point where even if you are not getting hit with an accumulator now, it's very likely that you will either next year or shortly in the future. So for that reason alone has become one of our prime policy priorities. And the biggest problem with copay accumulators, as many of you know, it can be impossible to find in your plan document, even for people that are really experts in this field. Insurers play hide the ball with this as much as they can. So you can have a plan document that's hundreds of pages long and find this language buried in a footnote on a single page. It's disguised very often under names that are very confusing. Copay protection programs, specialty copay solutions, anything to sound like it's not something that's harmful to the consumer. And in many cases, the language can be discretionary. You could have had this language in your plan for several years. Florida Blue is a perfect example. They've had it for 2 or 3 years, and just this year decided to, again, completely without notice, say we're going to start applying these for this coming plan year. And so for somebody that has researched their plan, done everything they could to find one that fits their medical needs, has their doctors and their networks, done all of their homework, suddenly, without little notice or even in the middle of the plan year, they can learn that the cost-sharing assistance they relied on to be able to access their treatment under this plan will not be available. Next slide, please. Now, the reasons why consumers need to be protected against these should be pretty obvious. Obviously, the big point to make is always that copay assistance or cost-sharing assistance is a lifeline for anybody with bleeding disorders. They simply cannot access the treatment that they need. This can put you clearly in a life-threatening situation when you're forced to pay $8,700, go deep into debt to try to find a way to afford this, and have no way to protect against it in advance. They also are very counterproductive simply because they're shifting costs to patients in a way that's forcing them to no longer be able to continue on their treatment. And very often that puts them into more costly treatment settings, like the emergency room, for example. And then another key point to make is that insurers are double dipping here. They aren't saying, well, copay assistance is bad, so we're just not going to accept this. We're going to return the money back to the pharmaceutical manufacturer. No, that's not what they're doing. What they're doing is pocketing this money. They're keeping it for themselves. It's going straight to profit while they're still collecting the same amount up to that cost sharing limit from the consumer. So we call that double dipping. And a great example we use that you could probably use in your meetings as well is if you were getting a scholarship, for example, for your son or your daughter or yourself, and you were getting that from a third party, you were relying on that scholarship to go to a prestigious university. And then when you show up the first day, you find out that the money for that scholarship is being kept by the university, and they're forcing you to pay the full amount of that scholarship to continue to going to the school. Obviously, that would be a completely outrageous situation, and this really is no different. Next slide, please. So fortunately, at long last, we have a federal bill that will help provide protections for those plans that are federally regulated. So the large employers, self-funded plans where most Americans get their coverage. A number of you are well aware and have worked on the successful state laws that have already been passed in 12 states and Puerto Rico. However, those laws can only do so much. They can just regulate state-regulated plans, the individual, small group, state employee plans. And that's only about 20% of insured consumers. So the federal fix was something that we really needed to see, especially since CMS, Centers for Medicare and Medicaid Services, which regulates these plans, has refused to act for the last couple of years. So we've been pushing for this bill for a long time. We finally have it. It is a bipartisan bill. It's been introduced by Rodney Davis from Illinois, a Republican, as well as Representative McEachin from Virginia, a Democrat. And it will specifically require that insurers count the manufacturer cost-sharing assistance towards all of a consumer's cost-sharing obligations. And it specifies what those are: the deductible, the copay, the annual out-of-pocket maximums. It goes, however, beyond the state laws because it addresses this loophole that's come up just over the past year. And this is really a confusing area. I don't want to get into a lot of detail about it because most of the people that you'll be talking to won't really be aware of all the details as well. But it's important to know that this bill goes beyond the state laws in trying to protect against this loophole. What we've seen are insurers basically taking advantage of the ACA essential health benefits requirements in a way that lets them declare drugs or a whole class of drugs as non-essential and then not have to count the amount of the cost-sharing assistance towards the cost-sharing obligations. This bill says no, they can no longer do that. It makes it very clear that it applies to all of those. So there is no situation where an insurer can do that. Basically, as it says here, all cost-sharing assistance has to be counted for any covered service. Now, there is another issue that's come up with high deductible plans in Illinois and some other states. Again, it's very, very complicated. It's basically there was some federal guidance from the Internal Revenue Service that's being interpreted to say that basically the cost-sharing assistance cannot be counted towards the health savings accounts that you can contribute to that typically go along with a high deductible health plan. An issue that is so confusing that in a meeting, you're probably simply going to confuse the person that you're talking to. It'd be an ideal situation to provide details and a follow-up. But the important thing to note is that this bill, if that issue comes up, does not specifically address that, but that's something that we're still having to work on at both the state and federal level. And that's an area where we're continuing to advocate to make sure that guidance is modified in a way that won't cause a conflict with federal law. Next slide, please. So the message to the representatives or senators when you're talking to them tomorrow, again, the most important point is to make clear that this literally is a lifeline for consumers with bleeding disorders. Again, this is something that's exploding, increasing quickly. Most consumers are going to be hit with this in the future. And stress on them, even if you're not in a plan where you have accumulators right now, stress for them what would happen to you if an accumulator would be applied. What this would mean in terms of not being able to get the treatment you need immediately, and how that would impact you, not just health-wise, but also in terms of the financial insecurity that you face, trying to come up with the money, either going into debt or borrowing or what have you, to try to have to cover that $8,700 completely unexpectedly. Again, just put it in personal terms, tell your story about how that would impact you if that accumulator were applied on your plan. And the other important point to make is what I touched on before. Copay assistance does not in any way drive people with bleeding disorders to higher cost brand name drugs. There is no other alternative, as is the case with 95% of specialty drugs. There's no cheaper low cost alternative that you can go to. And that's the number one point probably to make sure that they are aware of. Again, this is something that states have acted proactively. Make sure that the person you're speaking with is aware of that, but make sure that they're aware that by co-sponsoring this bill, or if they're a senator seeking companion legislation, they're helping to go beyond what states have done and address the area that we need to have federally fixed, which is those large group and self-funded plans.